My name is Axel Grothey. I'm a medical oncologist at Mayo Clinic in Phoenix, Arizona. I'm here to discuss, as part of a roundtable discussion, optimization of late-line therapies in metastatic colorectal cancer. With me are Dr. Bekaii-Saab from the Mayo Clinic in Phoenix, Arizona, and Dr. Eric van Cutsem, providing a European perspective from Belgium Leuven. Yeah.
Thank you.
Great to have you here. So we'll talk about late-line therapies or the later-line therapies in metastatic colorectal cancer. And a lot has changed in the last 5 to 10 years. Eric, so what's your perspective on what are key drugs, key treatment approaches that people need to be aware of?
Well, indeed, a lot has changed, as you said, Axel. And we have seen for the late lines of therapies two new agents that have been approved, regorafenib and trifluridine. Both agents have been approved.
So there's TAS-102.
TAS-102, yes. In Europe, we always say trifluridine. But these two agents...
sounds long, you know?
Yeah, but that's the way it is. That's a generic name. These two agents have been approved. They have some benefit for patients. We don't have head-to-head studies for these two agents, but they contribute to the longer survival. And as you and others have studied in the past and have published, every time we can add a new agent to our therapeutic strategy, to the algorithm, it seems that we improve the survival, not spectacularly, but with a couple of months extra, and that's important for the patients.
I mean, you know, the point I always like to make is we haven't really seen this one breakthrough event in colorectal cancer, except perhaps something we'll talk about later, the immunotherapies in MSI-high and mismatch repair deficient cancers. But patients benefit from the steps that we have seen over time. The more agents we have, the more we are able to influence the disease course, the longer patients will live. Tony, you know, so regorafenib and TAS-102, so what are some of the key aspects of these agents in terms of what are the data based on, and what do you think are the challenges here?
So the two agents that have the space in the refractory setting are TAS-102 and regorafenib, and they're different drugs. TAS-102 is a cytotoxic agent. It's a part of the superfamily of fluoropyrimidines. It's not 5-FU. It has differences with 5-FU and capecitabine. It tends to, in preclinical models at least, to have activity where 5-FU fails because of its properties. Regorafenib is a multi-kinase inhibitor, targets VEGF, but also targets other elements in the tumor. So they're different in their composition. They don't have overlapping activity per se, and their toxicity profile, and we'll talk a little bit more about this, are somewhat different.
Yeah. So Eric, you were involved in the development of both agents on the phase 3 level. So we have the CORRECT study, CONCUR, we have RECOURSE, and we have the TERRA study. Can you give us some of the results of a high-level overview and the difference between CORRECT and CONCUR in the different studies for TAS-102?
Well, if we just make a global summary, both agents led to, the use of both agents led to an improved survival. That was true for as well the regorafenib versus placebo studies as the studies of TAS-102 versus placebo. The amount of benefit was very similar, but we don't have cross-trial comparisons, so we don't have data comparing TAS-102 with regorafenib. It's always regorafenib versus placebo or TAS-102 versus placebo. And the design of the two pivotal registration studies with TAS-102 and with regorafenib were quite similar. Chemorefractory patients, refractory to all available agents, being fluoropyrimidines, oxaliplatin, irinotecan, bevacizumab, and in the wild-type, RAS wild-type patients, the anti-EGFR antibodies. These patients were randomized between placebo or regorafenib, or in the other study, placebo or TAS-102. And there was always a survival benefit. There was as well a progression-free survival benefit. And there was no there were no clear objective responses, with a few exceptions, with as well regorafenib as TAS-102. And then with regorafenib, we have seen two different studies. The CORRECT study, which was a pivotal study, which you and I had the privilege to guide and to lead. And this was a global study. And then there was an Asian study, the Concord study, in which patients were a bit less heavily pretreated. Patients were pretreated with the cytotoxics, but not with all the biological targeted agents. And also in the Concord study, there was a benefit. The benefit seems to be a bit higher. The hazard ratios were a bit more favorable in this Concord study. And then with TAS-102, we had the pivotal RECORE study, in also heavily pretreated patients. And before that, we had a Japanese study, a randomized phase 2 study, and then recently also the TERRA study. And also here we see similar results, TAS-102 with a benefit over placebo. And in the Japanese study, the initial Japanese study, the benefit seems to be a bit higher. That's probably patient selection in this situation.
I would agree. Now, Tony, you know, these drugs, as you mentioned, have different mechanisms of action. It's a kinase inhibitor, multi-targeted kinase inhibitor for regorafenib, with potential kind of collateral damage, you know, side effects, you know. And by the way, we actually don't even know how regorafenib really works in one patient. Could be a signature effect, etc. And TAS-102 is a conventional cytotoxic agent, you know, like a fluoropyrimidine. So what are the implications for side effects and side effect management here?
Yeah, so they're a little bit different. The toxicities with TAS-102 are traditional toxicities that you would expect with cytotoxic therapy, primarily neutropenia, but also other hematologic toxicities. There's also GI toxicities and cumulative fatigue. You know, in this line of therapy, the difficulty, of course, with assessing toxicities is most patients have little exposure to the drug. The few actually that benefit and continue through the drug, we understand a little bit more about the later toxicities. Regorafenib, on the other hand, has very immediate toxicities. In the first 2 to 3 weeks, you will see some of its signature toxicities, if I may say. Hand and foot syndrome can be quite severe in the first 2 to 3 weeks. 15–17% of the patients will have grade 3. Fatigue, again, something you see in this line of therapy across all agents. It's a function of the drug, but it's also a function of where patients are in the disease. And there are, of course, other toxicities that are particular to these TKIs, diarrhea, a little bit of hypertension. But overall, you know, the toxicities seem to relate to the mechanism of action. With regorafenib, unlike other TKIs, you tend to see those toxicities a little bit earlier. Regardless, with both agents, those toxicities tend to happen in the first 4+ weeks, at least the toxicities we need to pay attention to, like febrile neutropenia, for example, with TAS-102, or hand and foot syndrome with regorafenib. And for those patients, we tend to follow them very closely in the first 4 weeks to adjust for the toxicities.
Okay. Yeah, so when I look at these two different agents, the toxicity profiles from a patient perspective are quite different, you know, because patients normally do not feel asymptomatic neutropenia. And patients that I've had on TAS-102, except for the fatigue, you know, probably also an effect of this later line setting, they sometimes don't even know whether they're on the drug or not. So you could potentially really run a placebo-controlled trial. For regorafenib, things are different. And so, Eric, how do you communicate this to patients in terms of what they can experience? And are there some guidelines, you know, what you tell them how to prevent or communicate with you, and how often do you see patients in this setting?
Well, with regorafenib, this is very important. It's also important with TAS-102. With TAS-102, what we tell to the patients is mainly with neutropenia that they should call and if they don't feel very well, and watch their temperature, because although more than 30–40% of patients had a grade 3–4 neutropenia, there were only around 4% of patients with a febrile neutropenia and an infection. So, but they should know that, of course. With regorafenib, we inform the patients of the different adverse events that are potentially there. And especially this was more an issue in the beginning when we used higher doses. Today with the lower doses, that's a lesser issue. But we inform them that hand-foot skin reaction and or diarrhea may occur. And that what I usually do with my patients is I see them every 2 weeks in the beginning. but that after a couple of days, if they have some problems, they should call. But we see them systematically at day 14, all these patients, to figure out whether they are having some adverse events and to manage some of these adverse events. And on top of that, we inform them of some preventive measures, also to try to avoid hand-foot skin reactions.
I mean, you pointed out to hand-foot skin reaction. I think hand-foot skin reaction, fatigue, some voice changes, those are the ones that patients really feel, compared again to asymptomatic neutropenia for a lot of patients on task 1 or 2. So I do believe, and I completely agree, patient communication is important, and checking on them either by phone or by seeing them back, doing the liver enzyme monitoring, which is also important because we see some hepatotoxicity. Now, you already brought up, now that we're using lower doses, now, Tony, this is a ball kind of passed back to you because, this really kind of is related to a trial that you led, because a randomized phase 2 trial, the REDOS study. So can you elaborate a little bit what the rationale of the study was, what the key findings are, and then I would like to get Eric's perspective on, how does that really change the way you in Europe also approach patients with regorafenib, and will it make inroads into guidelines? Tony?
Yeah, so the study emanated from the fact that, as Eric pointed out, to the issues with regorafenib that happened early have led to a lot of different practices. I mean, before the study, you and I have talked about this too. Everyone had their choice of how to start.
What's the standard dose when the package insert dose?
The package insert is 160 milligrams. This is the study that came from the Correct for 3 weeks in a row and a week off, and that's been the standard dose, and that's what would be considered the standard arm, at least on the study. But folks in the community, used 80, 120, stop at 120, or started with 160 and then tracked down. There was no good way to understand how, because it wasn't addressed prospectively, to understand what is the optimal dose. So the study emanated from that fact, from the need to essentially understand whether a dosing strategy that starts with 80 milligram escalates per day for a week, and then going to 120 milligrams per day for a week, and then 160 milligram, again, if there are no dose limiting or related toxicities, and a week off. So that's a dose escalation strategy. On a weekly basis, go up by 40 milligrams until you hit 160. And the standard arm, or the correct arm, was 160 milligrams, as you would do it. And so there was the comparison. The primary endpoint of the study was a very creative endpoint that essentially tried to capture the essence of efficacy and toxicity. And so it was the percent of patients who would go through 2 cycles and then are able to start the 3rd cycle. So they have to have no toxicities that would limit them from proceeding further, but also they would have to have efficacy to be able to proceed to the 3rd cycle. And the study essentially suggested that the primary endpoint of and this was, by the way, this was a superiority study. So we were looking at the dose escalation arm being superior to the standard 160 arm, and the study was positive. We're looking for a 15% difference. We found about 20% difference, favoring the dose escalation arm, which was statistically significant, going from, again, 80 to 120 to 160 on a weekly basis. So the study, in addition to the positive findings on the primary endpoint, had another surprising finding: survival. Survival seemed to favor significantly, meaningfully, trended meaningfully, although not statistically significant. The dose escalation arm, close to 9-month survival versus close to 6-month, which is what you would expect from the Correct study, on the 160. Quite interesting. The arms were fairly well balanced. We couldn't find anything other than the strategy itself that could explain the differential in survival, so there was a positive finding. The toxicity seemed to favor more the dose escalation arm, not surprising. And also, when we looked at the quality of life of those patients, the quality of life did not seem to be compromised with the dose escalation strategy, seemed to be compromised at week 2, and then recorrected once the dose were adjusted on the 160 milligrams, so the standard arm.
So look at this, the readout study that you just talked about, the randomized phase 2, 123 patients. Well, that's kind of the filler between, we moved in the development of regorafenib from phase 1 to phase 3, and now we are redoing kind of optimization of dosing, kind of in between, which should have happened, in the way of the development. And I believe, if the 9 months could have been replicated and we had shifted, overall survival from 5 months to 9 months with regorafenib with an escalating dosing scheme in our study, Eric, we would have looked at regorafenib very differently.
Yes, that's right, and that's what we're integrating already today in also our clinical practice. And it's good that we now have these data, because until we had the data that were presented at ASCO GI, many physicians were indeed starting with 120 milligrams. Most Europeans don't start lower, don't start at 80 milligrams. We usually start at 120. But now we have the data, although being a randomized phase 2 study only, we have the data that endorses that this is a good strategy. And on top of that, there is a European academic study led by the Spanish group that is finishing now, and that will read out in the near future, later this year. Also looking at a different dosing strategy, and also with an arm of patients with 120 milligrams, not with 80 milligrams, but with 120 milligrams, so 3 pills a day. And I do believe that for patients that is the best strategy, and that's what you see also in clinical practice. Having treated a lot of patients, patients can go on with the drug for a much longer time, and that's probably the reason for the benefit, as Tony said, with this strategy.
I mean, if you see that more patients are going, almost twice as many patients are continuing treatment longer, and if you have a cytostatic agent like regorafenib, then of course, I mean, the benefit is actually quite plausible. Now, the NCCN guidelines have already kind of integrated this, as one of the options. Not yet preferred. I think, it's a phase 2, but I think people listen to that. What about in Europe? Could you consider this putting this into the ESMO guidelines?
Yeah, well, the mechanism of the ESMO guidelines is different than the NCCN. We don't update them every couple of months. But if in the previous and last published ESMO guidelines, we already say that the dosing of under 60 milligrams, the 4 tablets, that's really only for the very fit patients, and that physicians should be aware of the fact that this may lead in some patients to more excessive toxicity, and hence there is a suggestion that physicians could use the lower dose.
Yeah. No, it's interesting to talk about, the topic of our roundtable discussions, optimization of later line therapy. And sometimes it doesn't take a lot of tweaks, because, the tweaks are minor. It's pretty rapid ramp up within the first 3 weeks, of a dose. And it can lead to significant improvement. And this comes, of course, once we understand how these drugs work, limitations and the side effects, etc. So I believe it's interesting. Now, this also ties into some new developments I've seen at ASCO GI again, the so-called reverse study, and which I'll ask Tony about, and then we'll also like to talk about, to finish up the idea of later line therapy, immunotherapies, we need to talk about this, and HER2 targeted therapy. I think these are very important topics. But let's Tony, I'll throw the ball at you. The Concur study, which Eric mentioned before, in less heavily pretreated Asian patients, seemed to have a larger survival benefit than the Correct study. So what about other data moving regorafenib earlier in the lines of therapies? And what do you think about the data that were recently presented?
Yeah, so that's very interesting. So as you said, Concur does concur with Correct that there's a survival benefit, but the hazard ratio, both for PFS and OS, seem to be more interesting, and that's patients were less pre-exposed to the biologics. So Reverse was a study from Japan, large phase 2 randomized study that essentially looked at moving regorafenib ahead of cetuximab versus the reverse, meaning, cetuximab followed by regorafenib. So that study overall was positive for its primary endpoint, which suggested essentially regorafenib followed by cetuximab strategy improved survival over cetuximab first, followed by regorafenib, which essentially goes with the spirit of Concur, meaning trying to move regorafenib earlier in the biologic scheme seems, for some reason, to improve outcome, overall outcome versus the reverse. And this effect seemed to be primarily driven by moving regorafenib, not by moving cetuximab one way or the other. Cetuximab kept its value, whether you give it first or later, but regorafenib seems to have gained value when you give it first rather than later. Now, granted, this is, again, a phase 2 randomized study. It's also in Japanese population, patient population. And I think it's important. It's an important study because now this is the second study that suggests moving regorafenib perhaps to earlier lines, a little bit earlier. I wouldn't say earlier lines, but a little bit earlier may actually improve outcome for patients, and certainly needs to be validated further, either in Western patient population or in a more global study.
Yeah. So, I mean, just to highlight, I mean, the difference in survival was 6 months.
It was
something
6 months.
We cannot completely
It was pretty
ignore. I
significant.
mean, that is a big difference in this later line setting.
Yeah.
I mean, that's the median survival of patients, of untreated patients in the setting.
It was pretty impressive.
So whether or not we'll ever be able to see a validation study remains to be seen. You know, is this the right time? Because, of course, you know, there are more interesting topics. You know, people jump on immunotherapies all the time. I mean, there's almost, whenever you have the label of immunotherapy in a trial, in a later line setting, however, you know, attractive this might be for us, patients love it. And so, Eric, where are we with immunotherapies in later line setting? And I want you to highlight on to break it down by MSI high and MSS patients.
Yeah, what we do know today is that clearly patients with an MSI tumor, and around 4 to 5% of patients with metastatic colorectal cancer have an MSI, microsatellite unstable tumor, they clearly benefit from a checkpoint inhibitor. We have data from pembrolizumab studies, we have data from nivolumab studies, and recently also we have the data from the nivolumab plus ipilimumab studies. They all show that there is a clear benefit for the checkpoint inhibitor in MSI patients. And that's standard, that's approved in the US. That's, however, not yet approved by EMA, although we think scientifically that that's the best option for these patients.
What's holding it up in Europe? What's going on?
Well, there is a discussion with EMA, and these studies are not randomized. And that's probably one of the discussion topics at EMA, that they need and want to have a bit larger data sets. Personally, I do think that that's not a correct approach. If you see that, I've treated a lot of patients in clinical setting. If you analyze the data from the different published clinical trials, it's clear that these drugs are active in these patients.
And it's unmet need. I mean,
and it's a clearly unmet need. It's a better treatment option for these patients. That's for sure true.
Tony, what about MSS tumors?
Yeah, so unlike the microsatellite unstable or MSI high tumors, the microsatellite stable tend to be less hypermutated. In fact, some of them have a low tumor mutational burden, so they're less likely or unlikely to respond to immune therapies. So strategies to try to turn these so-called cold tumors into more hot tumors, invite those tumor-infiltrating lymphocytes into the milieu, may theoretically at least enhance the likelihood of these PD-1 inhibitors like pembrolizumab and nivolumab to have their effect. Preclinically, there are a number of strategies that have proven to be useful. The MEK inhibitors overall, although primarily in non-specific immunomodulatory agents, I mean, these agents essentially seem to inflame the tumor, make it more visible to immune cells, to T cells, and then when combined with PD-1, PD-L1 inhibitors seem to essentially have activity similar to what you see with the MSI. Similar, not the same. There are other strategies as well that are being developed that seem to make sense as well. And some of them are a little bit more specific in terms of activating T cells. And these are also being developed. But the one right now that's most advanced is the MEK inhibitor plus PD-L1, specifically cobimetinib and atezolizumab. The study was started as a phase 1b study. The first report on this looked somewhat promising. There was an update at ASCO GI for the phase 1b. That still places the response rate a little bit around 8%, 8 to 10%. Not as impressive as the initial data, but you still see some responses and some solid responses. The phase 3 study completed, and it was a study that looked at cobimetinib plus atezolizumab versus atezolizumab as a single agent versus regorafenib as the comparator arm with the hope to improve survival. So we'll have a little bit more data on that group of patients, should be somewhere in the summer. But overall, the strategy of trying to bring these immune therapies into microsatellite stable tumor is a very hot item. The preclinical data suggests that we can do it. Whether MEK inhibitor is the optimal way to do it or not, and whether if that study is positive, great, it creates a new standard. If it's negative, I still think that it would continue to be worthwhile to explore other strategies in this space because we can do it.
And it will likely not necessarily be positive for all patients. You know, from the data we've seen, there's probably a subgroup of patients.
There's a signature.
We try to look at, you know, who are these patients who can be, where the immune system can be activated. So last topic I want to talk about briefly, HER2 positive cancer. So Eric, we've seen data from my pathway study, from the Italian study, the Heracles study. And other studies are ongoing right now. There's a randomized study in the United States, an intergroup study. So do you test for HER2 amplification in your clinical practice?
Yes, we do test systematically in these patients for HER2 testing, especially the patients with a RAS wild-type tumor, left-sided, because they have a higher chance of being HER2 amplified. And it's around 3 to 5% of the patients who are HER2 amplified. So in the chemorefractory patients, went through the different treatment options, cytotoxics, and through bevacizumab and the EGFR antibody, we test systematically for MSI and for HER2. And if patients are HER2 amplified, then we propose them a treatment, preferably in a trial, but if there is no trial possible, we try to solve it also with the combination of trastuzumab plus lapatinib. It is shown that the combination is probably the better option. The Italians who did that xenografts and later on the first clinical study have shown that. This combination, according to the initial experience, reported in around 1 out of 3 of the patients an objective response. So this is again an unmet need population where we test and where we treat these patients.
And I think the intriguing part here is you have a biomarker for positive selection, and you see the responses without chemotherapy. You target biology, and I think this is critical.
Yeah.
Okay, very well. I mean, so we have options, and there's actually already outlined future options. So in this roundtable discussion, I think we explored real efforts to optimize later-line therapies using existing agents that we have available from a regulatory perspective, TAS 102, and in particular, you know, with the dosing strategies that Tony described with the readout data with regard to regorafenib, which I think toxicity management was an unmet need, is an unmet need. So I think we will hopefully see how this gets embedded into clinical practice. And new data, immunotherapies, you know, the holy grail of treatments making MSS tumors immunogenic, and then subgroups of patients like HER2 positive cancers. And hopefully we'll see a kind of a slicing down of further subgroups that will be amenable for targeted interventions. Thank you for listening. Hope it was interesting for you and for your clinical practice.